Alright, when you see it back there too.
Alright, so I'm Kari. I know most of you guys, and I've met you guys today, but I'm an SRNA student at Western, and this is just our pleasure giving back to you guys because you guys have done so much for us. And I'm going to start out with I know this is kind of a lot of information for you guys, and I mean, because we went over it over the course of 6 months during our first year, and so, I mean, it's going to be a lot of information for you guys, so I just thought that this might be helpful. These two, Henry Rodinger and Mark McDaniel, they wrote a book called Make It Stick, The Science of Successful Learning, and I just think that they had some really good tips about adult education, and so we'll get started on that. So the first thing that I want to say is don't just reread your notes and readings. The studies show that when you reread something, even if you read it like 5 times, you're not going to get any more information out of that text than when you first read it. So, I mean, the big overall point that I want to make here is you need to interact with the information, and I'll go through that a little bit more, but when you do the second reading, you tend to like read it through and you're like, oh, I know that, because you kind of think, oh, it's familiar, but it's not really sinking into your brain. So, and you have the false thing of, I know this stuff, when you probably really don't. That's what I get, and I'm like, fall asleep. So, the second thing is to ask yourself a lot of questions. That's the first way to interact with the information. So, throughout this presentation, I'll kind of give you guys an example of what that looks like while you're reading the text, because all the information that I present to you guys today will be from, like, almost directly from the textbooks that you guys got. So that'll give you guys, like, just kind of a head start on that. So read it once, then quiz yourself. And just retrieving that information is what actually produces more robust learning and memory. And it makes you understand it. You ask what questions, why does that work like that? You know, what makes that go, or something like that. So later on I'll be talking about positioning and nerve injuries and all that. And so one of the things I like to say is, okay, so that nerve causes this, but where is that in the body? And that kind of puts 2 and 2 together. Do both here. So connect new information to something you already know. This is where you guys are going to shine, because you know all this stuff. You have the visual knowledge of, oh, that's an anesthesia machine. When I was taught how to do an anesthesia machine, Hewer got up there and had this circle machine. I was like, what in the world is that? You know, at least you guys already know what an anesthesia machine looks like. And so this is going to be a lot easier for you guys, because you guys already know what propofol looks like. You know that when you push propofol, the patient goes to sleep. The only thing now is that you need to, why does the patient go to sleep? What happens in the brain? Stuff like that. So whereas we, first years, we were like, okay, having to connect all this stuff, you guys are going to be able to connect it a lot easier. So this is just an example, and this comes straight out of the book, but how a neuron transmits electricity. So this myelin sheath right here, that's what actually sends the impulse along the neuron. And so you can think, oh, well, so the breakdown of the myelin sheath makes the electricity go slower. And that's kind of what happens in MS. That's why people get weaker and weaker and weaker, because their myelin sheaths break down. You don't need to know that. But just so, think of like a hose, you have water going through it. When you poke a bunch of holes in the hose, you know, the water leaks out. So just stuff like that might be helpful. All right, so draw up the information in visual form. This is a picture of notes that I had from Hewer's class from pharmacology. And basically what I did was I took his notes, this is first semester, and I just wrote diagrams, and I just connected things, and, you know, and I like colorful things, and, you know, just drew stars and stuff like that. And I sent it to my sister, and she's like, the only thing I know here is hearts. So that's that's really helpful. Actually, I had my 7th grade teacher taught me how to do that, and I still do it to this day. So, and then a lot of my classmates use flashcards. And the one thing that I didn't realize until I read this was keep retesting yourself on stuff that you already know, because it's that memory, that muscle memory of your brain, and that'll help you later on connect things. And then one of the things that my study buddy, you guys probably all know Lisa, little Lisa, she's like really energetic, she's awesome. She and I use Quizlet.com, so she writes all these cards, and just go to Quizlet. You guys can all get on it and make questions and then quiz yourselves. And I can talk to you about that later if you want to.
There is a Quizlet that has some anesthesia tech questions on
Well,
it.
and see,
And they
I
are very amusing.
really okay. So you guys have already checked that out. I think that's a great way to learn, and then you can start things. So.
But if you all are interested in wanting to do questions and have it interact with us, I can help set something up for us to go that we can have our own Quizlet.
Yeah.
I think I already have about a third of the book in flashcards.
Okay, that's perfect. So just keep going through them, share them with other people. The other thing that Lisa and I like to do is get together and quiz each other and verbalize things, because then you have a little bit more connection. The other thing that I would suggest is don't cram, space out your studying. So we're starting now in January, and this is why I wanted to push for January. And I know that some of you guys are going to want to take the test in March. And however you guys have, spaced out your studying, but come up with a plan, be realistic. When I first got into anesthesia school, they're like, you have to study 14 hours a day, and I was like, oh no! And so what I ended up doing was studying 8 to 10 hours a day, and I would schedule that time and whatever I got done during that time, and then I'd pick it up the next day. So, but every single day I studied. So, oh, sorry. Oh, guys, we have to keep going. Okay. So this is pretty self-explanatory. Teachers should space out and mix up the lessons. So I was telling you guys earlier, we're going to have different presenters, and we're going to try to duplicate the information as much as we can. So there's no such thing as a math person, guys. So there's 2 mindsets about learning. One's a fixed learning model, and the other mindset is a growth mindset. So those are fairly self-explanatory, but I want to talk a little bit about the growth mindset. It says learning involves using effective strategies, putting aside time to do the work, engaging in the process, and then all of which it increases your capacity to engage with the topic. And so it turns out that the mindsets predict how well students end up doing. So it doesn't, if you're a math person, you're a reading person, whatever, it's actually that mindset of growth. I can do this. That's my pep talk, guys. Just listen. So this is my topic for today's operating room tasks for anesthesia technicians. And what is really humbling about this is that y'all know more about this than I do. So if I say something wrong, feel free to raise your hand and be like, you're wrong, that's not how we do it here, or, so I will not be offended in the least if you guys do that. In fact, one of the reasons that a lot of the students are presenting is to learn from you guys. And I've gotten that more and more from a lot of the students. They're like, we just want to learn from them because they know so much more than we do. So here we go. These are the objectives. And this comes straight out of the handbook from the anesthesia technician handbook that I sent you guys in the email. And these objectives are things that you guys will be tested on the exam. Out of this presentation, you'll get 10 questions from on the exam. So I know that I've said this a billion times, but thank you for helping us on our first day of anesthesia school. And this is a little, oh no, how did I get, we walk in, and we're like, what did we get ourselves into? So the poor little cat in the corner of the bathtub, like, what? And I actually probably only slept 2 hours the night before I did my first clinical. And so, anyway, I just want to say thank you guys so much. And so the purpose of this whole course is it's just to give you guys some direction. You guys already know this stuff, and so that's what my goal was when I talked to Professor Hewer about it. I just want to give you some direction, and we've already learned some of this stuff. Okay, so we'll get going. The certification exam in continuing education. So this is part of the objectives. Complete the registration form, including, so when you go to register for this exam, you get a copy of your high school diploma, a letter from your employer, apologize for the spelling there, detailing your work experience, and then obviously you have to pay the $400 if you're not a member. And then once your application is processed, your applicants are notified via email that you may register to take an exam, and then you have 90 days to register for the exam and take the exam. So that's stuff that you guys might already know, but it's in the objectives, so I wanted to go over it. So the exam itself is 120 questions, pulled from a bank of 1,500 questions. You're scored on 100 of those questions. 20 of those questions are going to be thrown out as research kind of questions. You have 3 hours to complete the exam, and then you'll receive a printout of your score. And the other part of the objective was how do you maintain your certification, and you get 2 years, every 2 years you have to prove that you've had 20 continuing education hours. And I don't know where you guys get those. Good luck with that. We got the peanut gallery, yes! Okay, so BLS and ACLS PALS. So BLS is required for you guys, is that correct?
Yes.
ACLS and PALS in Chapter 49, it's just a great idea to get. If you guys can possibly get your ACLS PALS before you take this exam, you're going to be light years ahead, and it'll help you guys with pharmacology, EKG readings, drug, all that kind of stuff. And then you guys will look like rock stars going down the hall coding somebody. So, yes, it's always a good idea to know what you're doing. Okay, these are legal aspects of the operating room, and feel free to fall asleep during this and watch it again. And I know there's a lot of information on these slides. I tried to kind of break it down, but it's in Chapter 55. So credentialing, promote patient safety, professionalism, and excellence within the profession. So I sent you guys an article, well, I sent Jeffrey, I will send the rest of you guys, an article that from the ANA Journal about anesthesia techs getting certified and getting like kind of more of a standard of education. And she was, the lady who wrote it was really excited about it because she wants to promote the whole profession. So, and then regulation, you guys all know about Joint Commission. They're gonna look at if you guys label syringes, and then how you guys do point of care testing, privacy. Do you guys do the HIPAA? You guys have to do the HIPAA modules and stuff like that. So you guys all know about HIPAA. PHI is protected health information. In the book, it just said, watch for labels, because you guys are going to be using labels, to put on labs or medications or whatever. If you throw those away, just, try to make sure that you dispose of them in a timely or a good way. And then open computer screens. That's one thing that that was kind of beat into my brain is don't ever leave an open computer screen up because you have no idea what is going to be done with it. And then consent. And we all know as students how important this is. But you guys are going to be helping with procedures. That was actually part of your scope of practice. And if you guys are putting in A-line, help putting in A-lines, central lines, in the CVOR, I know you guys put in, CVPs and stuff like that. So just make sure that you guys have a consent and know where that is in the chart. And if you catch it and no one else catches it, it can make you look like a rock star. or make the student look really bad. All right. Here's liability. A tort is a wrong resulting in the breach of a duty to another person, intentional or unintentional. So battery would be, I'm drawing this blood gas even though you're refusing to draw this blood gas. They can sue you for battery because that's harm done to that patient intentionally. Negligence is it's an unintentional tort. And I know those are kind of a lot of words, but they may or may not show up on your exam. So I would kind of be familiar at least with those terms. And then an anesthesia technician can be sued. So you can be, you're going to be liable for medical malpractice. So just read that last bullet point. Must only perform duties delineated by the job description and institutional credentialing. So you might have a bigger scope of practice at a different institution, but as of right now, JCO says that your scope of practice is delineated by the institution. So I don't know what that means for you guys, but if you guys have a copy of your job descriptions, that would be helpful in the future, probably. Here is a kind of an example of what you guys all do. It's amazing. So I know you guys can't see it really well. You guys will get a copy of the PowerPoint for, at your leisure. You can look at it. But look at all the things that you guys do and are able to do. And so up here you have administrative duties. This whole right here is your common duties. And then you have works frequently with. You're going to have to work with anesthesiologists. I mean, you guys all know what you guys do. So I just thought that was really cool. Okay, here's an overview of a patient going through surgery, and I just went through this really quickly because you guys all know this. Patient goes to the surgeon's office, gets a little ultrasound, yes, you need surgery, and then patient shows up for pre-admission, and that's when they get their weights and labs and all that kind of stuff. And, they find out you have this huge heart problem, so you go in for more testing and all that kind of stuff. So that's the pre-admission. And then you come in admission. So most patients, I don't know exactly in the heart tower, but most patients come in around 5:30 in the morning to start getting their vital signs taken and get, they have to show that they have insurance or don't have insurance. And that's not my duty, so I don't really know a whole lot about that part, but that's part of their experience. And then they get to pre-op holding. They have to take off their clothes, get into bed, and that's where they get blood drawn and all that kind of stuff. And then the operating room, you guys know about the operating room. That's your job. Like, that's y'all's kind of thing. And then the PACU. Transport of patients is getting to be a bigger deal just because there's more anesthesia done in other parts of the hospital. And like MRI and ultrasound and stuff like that. And you guys all have to know all about what your resources are. Do you have an difficult airway card and all that kind of stuff. So, catch up with me. So that's chapter 50. And I know a lot of you guys brought your books, so that's awesome. And if you guys want to follow on, that's fine too. But the biggest things that I took from this chapter, monitoring during a transport, you have to assess the patient's oxygenation, ventilation, and circulation. So here's my questions. What does pulse oximetry monitor?
Oxygen saturation.
Yes. So pulse oximetry measures the percentage of hemoglobin saturated with the oxygen. What are the limitations of pulse oximetry that you could possibly think of if you're thinking about, you're assessing the patient's oxygenation? What if the patient's moving around, flailing around? You're going to get a good pulse oximetry? No, probably not.
Their hands could be cold.
That's great. Their hands could be cold, you don't have good perfusion. The biggest thing is that when you start seeing a patient's, that little line go boop, 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 that's actually a late sign of poor oxygenation. So that's kind of a limitation. Patient could be taken along at 99%, 100%, and then kind of go do, and you're already kind of behind the 8 ball. So
Start changing colors.
that's definitely a late sign. That was not in the book, but yeah.
Have to do something.
That's how they used to do it. Oh, those lips look kind of blue. What? So what is the best monitor for assessing ventilation? Can you guys think of?
CO2 monitor.
Yes, good job. So an end-tidal CO2 through the use of capnography, which is a measurement of the exhaled CO2. So next time you guys are helping out with like an induction or whatever, look over to your monitors and see when the patient breathes out and fogs up the mask, what it's doing on the monitor over here. You'll see that wave go up. It's a white wave, and then yeah, I mean you all know what I'm talking about. But just kind of look for that correlation and start putting these things together. Oh my goodness, guys. Okay. Oh yeah. Okay. Here we go. What are 2 simple and reliable methods of assessing circulation during transport? Don't think too hard.
EKG?
Yes. Good.
I just read this morning.
So here we are interacting with this material. And blood pressure. So non-invasive blood pressuring or art lines, So that's and then A-line blood pressures. You all in the CVOR and probably spines and stuff like that. You guys are going to have A-lines. That pressure bag is to keep the arterial catheter patent. And this was kind of interesting. I just put this in for kicks and giggles. And you guys might do stuff differently. Apparently, once the patient is getting ready to transfer from the bed over to the stretcher, you can put the bag on the patient a little bit, but as soon as you can, put it up on the line. So why is the hurry to put it back up on like a pole?
You don't want to restrict the flow
Okay.
in any way.
What happens if you get air in that line?
An embolism.
Yeah, exactly. You could get embolism. And so that's why it's important to try to maintain the patency of those lines, especially during transport, because spaghetti to the max, right? You guys all know that from the CVOR. I'm sorry, did I say spaghetti to the max? Okay, continue. The prevention of hypothermia. So this is another big thing, and we got Professor Degman talked to us about how hypothermia is such a big deal and keeping your core temperature, especially in trauma patients. So you get an increased incidence of post-op wound infection and myocardial ischemia or a heart attack. And you may or may not know this. I didn't know this until I got to anesthesia school, but general anesthesia actually takes away your ability to maintain and regulate your temperature. So y'all's job is, when we're transporting, is to make sure the patient's covered, nice snugly and warm, and if you have a ventilated patient, consider a humidified moisture exchanger, and that just keeps the moisture and the heat, because you do have insensible losses from breathing, and you can decrease your temperature, so you guys all know that. So management of ventilation. You guys all know transport people to the PACU, to the ICU, intubated, hopefully not just regular cases, but you guys in CVOR will transport patients to PACU, intubated, and ICU. So the biggest, you can have a transport ventilator, and you guys all probably know where those are, but the biggest thing is, squeezing the bag down the hall. And I remember the first time I got to do that, and I thought it was so cool. And I was like, look at me! And I actually had somebody write out you're the awesomest or something like that. But I was really proud of myself, and I think I went home and journaled about it. But that's kind of not that big of a deal. So what is your role? What does squeeze the bag mean? When somebody says, squeeze the bag for me.
Give them a breath.
Okay.
Make sure they're being ventilated.
And how would you know?
Just
Okay, yeah. So in the book, what it says is to make sure to kind of coordinate with your anesthesia provider. How many breaths a minute do you want me to give? How hard do you want me to squeeze the bag? Because they could be monitoring the end tidal and want you to be puffing down the hall, or hey, they're fine, just give them a breath every once in a while. My heartbeat was going like pitter patter, so I was squeezing the bag going down the hall, and I'm sure that patient was like, so just hyperventilating. So make sure you don't do that, and just that's one of the things that is in your scope of practice, and that you need to make sure that you communicate with your anesthesia provider. The other thing you can do is you can squeeze that bag really hard on a little person. You can
blow out their nose.
Yeah. See?
Most of the ambu bags now come with a restrictor on them.
Look at you. See, restricted. Most of the ambu bags come with restricted.
We got that on.
Awesome.
Hey,
See,
Kari,
Kari.
do they always say in the book, because I haven't read it all, that the CO2 is the, because I can see that kind of thing coming up on a question. Capnography is the
Gold standard. Yeah.
So
And
like when they often say, what's the best way?
Yeah.
Always pick that.
Yeah.
Always
Always pick
chest
that.
rise, chest rise is good, but if it has capnography, always pick that.
Yep. I'm going to repeat that. Always choose capnography.
Well, it
if that's
sounds
the
like a
question.
question I would ask you.
Yeah, I mean, it's a good question. So here is kind of where you, this is something that you might have to revisit this part of the presentation. The anesthesia technician, you have to have an understanding of how long given a supply of O2 will last. So if you have an oxygen tank, you guys as anesthesia technicians need to know, okay, it says 1200 PSI, and the flow is, they asked me to put it up at 4 liters. How many minutes do I have? Do I have enough time to get up to the ICU? Do I have enough time to get back to the PACU? So, I'm not going to belabor this because you guys can work out some of these problems on your own, but so a typical E-cylinder of oxygen is what we use for transport typically. You have a capacity, and this is what your book says, is 1900 PSI, and it's 660 liters of oxygen. So, math time, woo! Broaden your horizon. You guys are all math people today. Okay, tank duration. So this is really interesting. This is in the book, the PSIG, which is the pressure of the cylinder, and then you have the tank factor, which the E cylinder is 0.28. Now in your books, if you guys want to turn to this chapter, I think it's in transport. This tank factor is going to be 0.35. And this is right out of your book right here. So the question is, at a flow rate of 8 liters per minute, a full E cylinder of oxygen will last about 78 minutes. And this is kind of how we did it. So you have 0.35 times your PSI on your gauge over your liters per minute of O2 flow, and that'll give your U minutes to emptying. And I have another one on the next page too.
It's on page 492 if you're looking.
Okay, 492. I just want you guys to be familiar with where it is in the book, because this problem isn't that difficult. It's a little bit conceptual too. So the question that they wrote in the book is an E-cylinder, and this will be on your exam, so I would definitely know how to do this equation. An E-cylinder of oxygen has a pressure reading of 1200 psi prior to transport. How long will this oxygen supply last with O2 flows of 8 liters per minute?
52 minutes.
Good. And this is how you do the problem. You have, and I'm going to let you guys work that out on your own, because we don't, even when we were taught it in anesthesia school, I was looking at the board like, what in the world? You guys might be a lot smarter than me, so, but there's that. And you guys will get this PowerPoint available to you, so you kind of work those out. The other thing that you can do is There's problems like this. There's problems like this on the internet too. So if you guys need extra practice, I did want to cover that though because it's 100% going to be on your test. Okay, electrical safety, and we're going to kind of go through these fairly quickly. So I put this figure up here. It's in your book. Harm related to the use of electricity can occur in 4 distinct ways. You have shock, implanted devices, loss of power, fire, and burns. So any electrical currents flowing through the body can cause electrical shock or burn. So you think of your patient when you think of kind of a shock or burn, but also think about your surgeon and your surgical tech too. And I've never seen it happen, but in the book it talked about a surgeon getting a jolt from the electrical Kari. So just think about that too. Electricity can interfere with the function of implanted devices, and we'll kind of go over that a little bit. And those are pacemakers or defibrillators. And you can also ignite fires. Woohoo! We'll talk about that. So here's shock. It's an electrical injury. So less than 1 milliamp, you can't even perceive it. 1 to 10, you get this tingling, warm sensation. 10 to 20, you get a muscle spasm. And it's the can't let go current where you apparently have paddles. And have you ever seen someone like fall back or, I don't know. So they like can't let go of it, but whatever. So, and then 100 milliamps is ventricular fibrillation and death. So if you were struck by lightning, which one do you think it would be? Probably the 100. So there's 2 definitions here. We have macroshock and microshock.
This is microshock.
Right, so microshock is less than 1 milliamp. The current is not perceptible. And that comes into play a little bit later. But microshock is anything that's greater than 1 milliamp. So say you have a pacemaker, like an external pacemaker wire. I don't know if you guys are all familiar with those, but they kind of come out with the, oh goodness, what's that called? Anyway, they're external, and they come out from open heart surgery patients. And that bypasses the skin, obviously, and goes directly into the heart. So a microshock actually has the potential to do a lot of harm with those types of patients. So the skin is actually a very, very good resistor against electricity. And so just think about those types of things. That's kind of what the book stressed. Okay, line isolation. And Professor Hewer, you might be, he actually taught us this in school. Okay, so this is how your OR is set up with all of your equipment, is line isolation. Now in your homes, you have that 3-prong, right? You have a neutral, you have a hot lead, and then you have a ground.
ASATT 2955. Dr. Shonda ASATT 2955.
Okay, so this, I wish I could like dance around a little bit. This over here is where your home is, and it's probably a good thing because I'd probably trip over this thing. But this is your home over here, and you're always going to have this little piece right here, and it's going to go to the ground, and that's how you ground, and that's how you don't get electrocuted at home. So in the OR. In the OR, you have this thing called an isolation transformer. So I'm really nervous about this because Professor Hewer taught this to us. Okay, so it is really complicated. I'm trying to do it as best as I can to make it not complicated. But essentially, the line 1 and line 2 with the isolation transformer don't have a ground. So even if, say, there was a leak or something, I had this all like in my mind.
The bottom line is it's isolated from the mains power.
Yes.
Line isolation. There are alarms in the operating room. You'll be able to find them where they are already. supposed to detect the amount of current that's leaking from various pieces of equipment. And if it gets too much, the alarm will go off. But it doesn't cut the power off. It just tells you there's a leak somewhere. There's some faulty piece of equipment somewhere. And that means you can get a shock. So if the line isolation monitor goes off, you're supposed to go look around and see what piece of equipment is faulty. So like Kari has the slide, you're supposed to take one piece of equipment out one at a time. If the big monitor for the whole line goes off, then you know that's the piece of equipment that's broken. If it doesn't, you go to the next piece of equipment, you plug that one, plug it back in again, so you find the one's broken. So it's, I mean, I wouldn't get too bogged down in how exactly it works, because it is confusing. But it's just, the idea is that you won't get a shock for small amounts of leakage.
So actually, this is probably the more important slide, the line isolation monitor, because you guys will see this in the operating room, and there's questions about it in the back of the chapter. But so the alarm goes off. Does the equipment shut off?
No.
No. So what you're supposed to do, like Professor Hewer was saying, I'm just repeating it so they'll get it on the recording, but unplug your equipment one piece at a time, starting with the last piece that was plugged in. I don't know how you guys find out what piece of equipment was last plugged in, but good luck. And then the significant advantage of the line isolation monitor is that the equipment will continue to function, like I said, and you guys said, and then critical life support functions will not be interrupted.
That's different, like to a breaker at home.
Right.
The whole power circuit would shut off. If there was a fault, everything would go off.
And this basically,
undesirable in your life.
yeah, this basically just tells you there's a leak somewhere, or a piece of equipment is not functioning properly.
We had this happen not long ago
Oh,
in
you
COR
did?
24.
What did you guys do about it?
We ended up calling Biomed.
Okay.
And they sent an electrician up, and he ended up finding the issue, and Biomed ended up figuring out that it was the power strip that was plugged into. They think fluid got down in it and was causing the panel to alarm.
Okay. So in the book, when I was reading the book about this, basically what they said that the anesthesia tech, your job is during that time, is that you guys should know about the equipment, what kind of equipment is plugged in, and be able to kind of troubleshoot. So I don't know, I wouldn't be able to do that, so I'm glad you guys are going to be able to do that. And so it just talked about taking those equipment out and being able to kind of troubleshoot with that. So.
That's the only thing to remember. That, and it's isolated.
And it's isolated, yes.
You kind of guess that from the name.
Yeah. I was trying to go through that. I was going to that last night. I was like, line isolation monitor. No. Okay, so burns. Anybody know what this is? Yeah, okay, good. A given current flowing through a small area will produce more heating than the same current flowing through a large area. So you get a bogey, that's the electrical Kari. Obviously, because the pencil tip is small, you're going to get a high current. And you guys ever taken off those jelly pad bogey? So why do you guys think that those are there? Yeah, I mean, essentially what happens is if it's dispersed over a larger area, it protects the skin against burns, so it kind of disperses that. So, but if the conductive gel is dried out, the pad is incorrectly applied, then you can have an issue. So, if you guys do you guys ever take off those pads? I never watched them. I'm like, is the patient breathing? So, yeah, so just look at those, and that's what that means. Okay, bogey site's good. That's what that means.
Can I just go back to one thing? I'm just looking at the book, the shocking thing.
Oh, yeah, please do.
So micro shock and macro shock. The important thing about micro shock is you have to worry about it with susceptible patients. So those susceptible patients are the people that have an external pacer that's directly connected to their heart, or maybe they have when you're putting a central line in, they have those wires. So when it's connected directly to inside the patient, then they're susceptible to micro shock. For anybody else, it doesn't matter. It's not going to cause any problem. And then it's macro shock as well, right?
Yep. And that's all in there, and I had those notes down there, so when you guys get the PowerPoint, you'll get the notes at the bottom. This question was so where would you want to put a bogey pad?
On the like the fattest part of the person, I guess.
Yeah.
The biggest part.
So well muscled, typically on the thigh, arm, buttocks, if you want. It should not be placed over hairy areas because it's not going to stick, right? And over bony prominences, you're not going to get a good seal, or metal prosthetics. I mean, you guys would pretty much not pick that one anyway, so not gonna. So implanted devices, pacemakers, implantable cardioverter, defibrillators like ICDs, cochlear implants, spinal cord or other stimulators. Our goal is to prevent malfunction of these devices. So your dispersive pad that we just talked about, the Bovie pad, you need to place away from the current so it does not cross the device, but instead travels away from it. So if you're a patient, you're working on the, so if you had a left pacemaker, you're working on the right shoulder, where would you not want to put the Bovie pad? Right here. Yeah, so you're not going to want that crossing over.
Put it on the leg.
So it'd be good to get it away from where the...
Yeah. So one of the things that you guys did for me when I had a patient who had a pacemaker, and I was like, we need a magnet. And you guys knew where the magnet was, so you guys know all about that. And so you want to be able to know where those are. And I think I put, okay, so this is in my... Do you have anything else about implantable devices?
I would just say, so you CV guys may know this better, but so we put a magnet on a pacemaker, it makes it go to a set rate, it just goes 80 beats a minute, it just stays like that, regardless. So it doesn't get confused by the electricity. So if you put a magnet on, it'll work fine. If you put a magnet on a defibrillator, an ICD, you'll turn it off. So that's the emergency way to do it. You can also program it. You have a program that can do it. The magnet on the defibrillator will turn it off when it's shocking. So, does that make sense?
So, just to reiterate, the magnet on a pacemaker will make it go at a steady rate. A magnet on a defibrillator will turn it off.
Defibrillator function, so it will not defibrillate. So what would you need if you have a patient who has a defibrillator and you put the magnet on it and now it's off? What might you need to get in the anesthesia tent? What if that patient... Yeah, the crash car. So what if they go to defib, now they have no defibrillator? Well, I guess you could take the magnet off.
And the patient's
You
like,
can see RNA, take the magnet off. So yeah, think about that.
I know I went through that really quickly. Those are kind of the highlights from the chapter. You know, I don't know how in depth they're going to get about those kinds of things, so just hit the high points with that. So fire, do you guys need a break? Oh my goodness, I've been talking for like an hour now. Do you guys need a break? Do you want to go to the bathroom? Anything? You guys are more than welcome to get up, yawn, dance around. I don't care. It's good. I mean, I can stop, but you guys good. Okay. So fire safety is chapter 52. Apparently there's 600 surgical fires a year. Apparently those are underreported. And so you have a fire triangle. And I'll you have an ignition source, a fuel, an oxidizer, and then the most common ignition sources are electrical surgical devices and lasers. Go back there. And then oxygen is the most common oxidizer.
I would say that's important to remember that.
I would say that's pretty important, yes.
Yeah, so that's commonly asked too. What are the three things you need to manage fire?
Yeah. So what kind of fuels do you guys think in an operating room that are they're good sources of fuel?
Yeah.
What now? Alcohol?
Kind of,
Yeah.
Lots of alcohol.
Yep. What about the blue stuff, the drapes?
Drapes.
Yeah, those are good.
Drink filters.
Yes. Yes.
Oh,
ETs. So those are airway fires, and that is a emergency situation. There we go. Oh, yeah. And that's that. Fire safety, team effort. So be mindful of O2 delivery. So anytime you're using things like lasers or anything electric cautery near the face, I don't know if you guys have heard the circulator ask the anesthesia provider, how much O2, is it less than 40%? So anytime you're using anything near the face, you're going to try to keep that O2 below 30%. And that's something that, I don't know exactly in what situation that you guys would use that, but it's good to know if you guys are helping out in those types of surgeries. So you guys all know where the laser-resistant ET tubes are. Do those come with the car? Do the laser people bring those, or do you guys have them in your
They're
core?
in the core in the small, right? Yeah, they're in the, we got
They're-
them in a core, but
You have them in the core?
either we'll get them or the circulator get them. So
Okay.
they only go from like 5 to 7, I think.
Yeah.
There's no
Okay.
half size. 5 to 8. There's no half size.
There's no half sizes. Okay.
Just saying.
Yeah, no, that's good. That's good information. So you guys all know where those are. We have them here. So lasers, light, this is the acronym, light amplification by stimulated emission of radiation. And again, this is a little bit getting bogged down in information, but 3 main components are required to produce a laser light. You have to have an energy or power source, an active medium energized by the power source, mirrors used to amplify and channel the energy from the active medium to the light that's emitted. So with lasers, you can get risk of eye injury, they're a huge fire hazard, and air contamination. This is something that I thought that was interesting, which I would put a little star by. I need to be kind of mindful of it too, but I don't know, do you guys handle the lasers at all? Okay, well, just in case you do, here's something to be mindful of. So there's little mirrors inside the machines, and if those mirrors get broken or misaligned, you get freaky laser wave beams. So it could do a lot of damage. So those should be just FYI. Laser machines should always be on standby mode when not being in use. So if you walk into a room, laser machine for some odd reason, the laser guy is talking to the circulator about what they did on Friday night, and you come in like, oh, that's still on, turn off. Not that that's ever happened here, I was just making that up. So eyewear. Typically here at Mission, what I've noticed is that they give out the eyewear, but you guys might be entering a room or something like that, and those are hanging on the doors. So basically lasers go like waves of light, or waves, they travel in waves, and they can be absorbed into different types of tissue. So you have superficial, you have the cornea, and then you have the deeper part of the retina. And the different eyewear, this is why it's so important, has been designed to absorb the specific wavelength originating from that particular laser. And then you guys should all see a sign posted on that. Do you have anything else about lasers?
Just look at the questions real quick.
Okay.
Thank you.
Yeah.
Yeah, fire triad.
I mean, I think essentially in y'all's job that there's laser reps. Is that how it works here? There's people who do the lasers, so just the.
I mean, really, there's big risks of lasers are eye injury.
Mm-hmm.
I mean, it's complicated, the details, but they, like Kari said, you have to wear special glasses. You all know that anyway. Eye injury, you can get these kind of fragments of tissue that are harmful to be breathed in when they start actually using the laser.
Yep.
And then burns just from putting the laser in the wrong spot.
Sure.
Airway fire. I think that's the main one.
So going along with lasers, this is some equipment that you guys might be using. Jet ventilators, non-intubating technique used for laser airway surgery when the surgeon wants to completely uninstructed view of the airway, and then you have a specific laser endotracheal tubes. So just something with jet ventilators that, FYI, There's a lot of pressure coming out, obviously jet ventilator, and it could get into the stomach of the patient, and so you can get a patient with distended abdomen could be an issue with aspiration. So that was also in the book, and that might be good to know. So we're getting into the topic of patient positioning, and this is something that is really, really important, and if you guys can help out with it, I know you guys all do actually, and it's awesome. But this is something that in the next couple weeks or the next couple months, if you start thinking about like the nerves that you're protecting and padding, things are going to just make a lot more sense of why is that person doing that. So the first position is supine, and that's flat on your back, right? So get your head in neutral, and I'm gonna talk about some of the different nerves too. This is chapter 19. This was a big chapter in this presentation. So always want your head and neck neutral. You guys know that. And so just be mindful of any time you turn, even like patient across the bed, just be mindful of that head and neck. I know you guys all know Robin Burgess, but she was like, so we did a prone case one day, and she's like, so what are you worried about, the neck, the IV, or the ET tube? And I was like, I know it's pretty obvious right now, but I was like, oh, I know. And it took me like a second, but it's the neck, you can't go back from a neck injury. You can always put another ET tube in, you can always put an IV in, but you can't always give yourself a new neck. So. No crossed legs, that's why we put pillows under your knees. That relieves that lumbar pressure. Make sure there's no wrinkles under the patient when he or she moves over. And you guys are awesome at like trying to get the gowns out. And then upper arms tucked, ulnar, which is this right here, against the bed and hands parallel to the body. And then you have your patient their arms abducted, or abducted less than 90 degrees. So this is how I remember this. You add to your body, adduction, and then the other one is adduction. So here, so that's how I remember it. You guys might remember it differently, but some of these terms might be on the test, and that will make it a little bit easier. And supinated just means out like this. And I just think of little David Copperfield, can I have some more soup? With the soup, He loves me so. Okay. Make sure your pressure points are padded. So make sure your pressure points are padded. This is something that was in the book that kind of was stressed. This is the concept of a stiletto heel versus, the impact that my heel would do to somebody's hand. So just think about a stiletto heel versus. Once you get those pressure points padded, it disperses that pressure over a wider area. Median neuropathies, these are primarily men 20 to 40 years old who stay in the gym all the time, they get these big muscles, and they can't extend their arms out like this. And they're like this, and they walk around like this, and it's awesome. They can't extend their arms all the way. So I know, have you guys ever had that? Like when you get a patient in, they're like huge, muscular, and I'm like, why aren't your arms going down? Well, they can't actually. So this is really important. Nerves become ischemic or dead when stretched more than 5% of the resting length. So even if you like put that arm down, you could get that median neuropathy with them. So basically all you do is put some extra towel or something to make it just in a neutral position for them. So prone, again, maintain your head and neck throughout the patient turn, watch all the lines, keep shoulders higher than head to avoid hyperextension, and we'll talk more about the brachial plexus injury because that's a big one, probably going to be on your test too. Arms on boards with a slight abduction.
4364.
You guys all know, what that kind of looks like. It's in the surrender mode. That's what it says in your book. I was like, that's a pretty good way of saying on it. And lithotomy. This is just a position to note. You're going to have a higher incidence of injuries with this position because it's not a natural position. And you can compress the femoral, stretch or compress the femoral nerve. You have increased risk of compartment syndrome related to leg holders, peroneal nerve injuries, and those are specific. Do you guys remember those calf holders? Not the whole boot holders, but the calf holders. Are you guys familiar with those? They're kind of old school. They probably, but those can do some pretty bad peroneal nerve injury, and you can get some bad injuries with those. Always raise and lower the legs together, and then lower slowly. And something that we need to know as anesthesia providers is that your blood pressure is going to lower once those legs come down. So just, I don't know, think about that if you want to. If you don't. Excessive flexion of thigh against the groin can damage the obturator nerve and the femoral nerve. And I'm going to have a little bit of pictures. There's actually pretty good pictures in your book with the patient positioning on this.
Kari?
Yes.
Well, I was just saying that here they like text the legs up and down one at a time.
Oh, really?
Try to slow down any tension.
Oh. Okay.
That's what it says in the book. That's what it says in the book.
The book says to lower them down together just so you don't have that stretch. So I guess if you're doing it one at a time, just be mindful of, does that look like it would hurt? Because it probably does. If it looks like it hurts, it probably does. So just be mindful of that. So I guess here at Mission, you do it one leg at a time.
And just when you look at these positions, just make sure you know which injuries go with which position.
Yes.
That's going to be key. These are
Yeah.
like this one causes a femoral nerve injury, this one's an obturator injury, and what you do to prevent it. So,
Yeah.
shoulders, not this one, but shoulders less than 90 degrees. So like Kari said, making sure the leg's not rubbing up against the leg holder for perineal injury or ASATT Cert injury.
And these slides I actually got from one of our professors. I'm going to get into some of the other things that your book covers, but this is just kind of you guys know these, and then we're going to connect them together with some nerve injuries.
Are you going to give us this PowerPoint?
Yes.
Okay.
Everything's going to be online. I know, it's a lot of information. It is a lot of information. I totally realize that. It's going to be online. Jeffrey's handling all that, so you guys can go back. That's why I'm not belaboring any of these points. I'm kind of clipping along. These are the highlights of what is covered in the chapters. But this is the common peroneal nerve injury. And as you can tell, so if your legs were up in those stirrups, any sort of pressure right here is going to, at any length of time, going to cause some injury. And what you get with that is your foot drops, and you can't walk. You know, so. This was actually a PowerPoint. Some of the slides were from Ben Wharton, and he said that he was really excited that I was going to use some of his PowerPoints for you guys. So lateral decubitus, what position is that? On your side, yep. So pat your dependent leg, again, patting, patting, patting. Peroneal nerve, again, if you're on your side, that nerve is right here. Upper leg straight with pillows between your knees. It's the recovery position. You guys all know, like during like hip surgeries and stuff like that, you guys put those pillows, but I'm not quite sure. Do they just put, how do you guys do with the legs in positioning with lateral? They just put pillows, right, between the knees. Yeah, it's not the recovery pillows. Okay. I was a little bit confused about it. I was like, wow, that's a lot, but okay. So obviously, neck neutral, chest roll in place. This is really important right here. Your chest roll should not rest in the axilla, right under here, because look at you have all those nerves. That's why you get ticklish. You have all those nerves under there, but under the ribs, caudal just means, this is cephalid, head, caudal, distal. Yeah. Down here, so it should be right here. Injury to dependent ulnar nerve if not padded against. And again, your ulnar nerve is right here, if that dependent arm right here. So in the next couple months, you guys are going to be positioning patients. Just think about, ooh, what nerve? am I thinking of right now? That'll help. Again, okay, sitting, 2 fingers between the neck and the jaw, hips and knees flexed, and out, stretch lowered. So your hips, I mean, you're literally going to be in like a chair position. You can stretch that sciatic nerve and cause post-op lower extremity weakness. The other thing about the sitting, I don't know if it was in your book or not, but if you get that head strap right there, and then all of a sudden, like you move the patient, and the patient goes like, what? Yeah, I mean, you can get, so just be mindful where that head is, and like you strap it down, and get that. So here's some of the pictures from your book. And they went, the positioning chapter in your book was all about neuropathies. So I just went through some of the different positions just to, because you guys know those positions. Ulnar neuropathy, you can kind of see where that ulnar nerve goes through. It's very, very, it's like against that. I mean, even like larger people, you're still going to have that bony prominence right there. So you're going to get claw hand. So basically, if you get an ulnar nerve, that's kind of what it's going to look like afterwards. And I have some notes down here that you guys can look at, but they're in your book. So just special attention given to patting the elbow and making sure it's not hyperextended or flexed greater than 90 degrees. Here's your brachial plexiopathies. And the brachial plexus is the somatic nerves that originate right here and then go up right here. So anytime you, and you're going to be more prone to these injuries in the prone or lateral positioning, and it's going to happen when your head is moved in the opposite direction of the arm, and it can stretch the brachial plexus. So here's a really good picture. I thought this was an excellent picture in your book, and you can kind of tell, and I'm going to move for just a second. This is where it is, and you're going to get that hyper, you can see right here, that's not normal. So here is where it's kind of neutral and all happy, and it's good. I thought your book did a really good job of explaining some of that stuff. Yeah, you can kind of look at that. Guys, we're almost done. We have 3 more slides. You guys are doing awesome. So the most common perioperative neuropathy involves the obturator and the lateral femoral cutaneous nerve, and I have a picture coming up of that. But just, okay, here's the 2 things that in your book kind of they stress. Hip abduction greater than 30 degrees, you're going to get a strain on your obturator nerve. Hip abduction greater than 90 degrees, you're going to get ischemia, which means dead again, on the lateral femoral cutaneous nerve. I know that's a mouthful, but if you practice it. And so hip abduction, you're going to get that a lot with some high lithotomy, which high lithotomy just means that your butt is kind of, even like the legs are so high up that the butt kind of comes off the table. You just know, like, that's going to cause some injury. Good, you know. So that's why you have to be mindful that, you know, if you're lowering the legs down, not to be stretching those nerves too much. Sorry, here you go. You can kind of see where the obturator nerve and the femoral nerve is. All right, summary. Like I said before, operating room tasks will be 10 out of 100 questions. Focus on these chapters, 1 through 3, 19, which is positioning, and then 50 through 55 is stuff like laser safety and fire safety and stuff like that. And then chapter 59 is the BLS and ACLS certification. And again, I would really stress, if at the end of these 10 weeks, you guys have the opportunity to sign up through the hospital, it's an excellent course and it'll make so much more sense to what you guys do as technician. Do you guys, are any of you guys ACLS certified? Okay. Is it offered to anesthesia techs? Can they take it?
I can find out.
Okay. I just think it would be excellent. And sometimes it takes a while to get into those courses, so you might want to just check that out ASAP, and the other thing is too ACLS and PALS, which is Pediatric Advanced Life Support.
Yeah, an instructor too.
We do have an instructor. If you guys aren't able to take it through the hospital,
Until he graduates.
yeah. But I don't see. It's part of your scope of practice. So I would really highly encourage you guys to do that. And if you haven't taken BLS lately, you might want to do just a refresher course. It's just going to help you guys out more. Any sort of information, it's going to make a little bit more sense. So and next week is infection control, and it's going to go a lot faster than this week. It's only 3 questions out of your 100 questions, and Jake is going to be doing it, so it'd probably be kind of a clipper session. But I've asked him to do the equipment, contamination, and sanitation and waste disposal is actually part of my week, but I thought it would make more sense with his infection disease. So just be mindful of that. So, but I would encourage you guys to start reviewing basic anatomy and physiology because that's week 3. And Brad, do you guys all know Brad? He's going to be doing anatomy and physiology, and it might be helpful if you guys just kind of are familiar with what's in the book. So that's it.
Thank you.
Do you